Hi everyone, we'll just give it a few minutes while people are still joining, and then we'll get started just a couple of minutes after 7, that's okay. For anyone who's still joining, we're just giving it a couple of minutes to let people join, and then we'll make a start.
I've put the link for the feedback form in the chat. Does everyone have access to see the chat? I only sent it to you, Sophie. I'll do that again.
Hey everyone, we'll just give it another minute and then we'll just get started. Okay, so we'll make a start and people can keep joining as they are. So hi everyone and welcome or welcome back if you've been to one of our sessions before. My name's Sophie, I'm an F1 at Stepney Hill Hospital in Stockport in Greater Manchester. For those of you who've been before, you'll know the format, but I'll just run through it for anyone who's not been before. And today's session is going to be on breast disorders. So how the session works is we give you a 15-minute exam style MCQ. So I'll time you 1 minute per question, representative of if you were in an exam. I'll not speak throughout that and we'll treat it like a mock exam. And then afterwards, we'll go through all of the answers with explanations on some key topics in breast disorders. You can use the Q&A function throughout the session to ask any questions, and you can probably see that Brad's kindly on the link and he's going to answer them as we go through, and anything that's not answered, I'll answer at the end. So I've just seen in the chat someone's asked about a feedback form for having to leave early. It's already in the chat function if you need that. So I'll get a timer ready and we'll start your times if everyone grabs a pen, paper, anything they need, and we'll start with the MCQs. Okay, so question 1. And question 2. Sorry, everyone, that's question 3. I nearly skipped it. And question 4. Question 5. And question 6. And question 7. And question 8, you're at halfway. And question 9. Question 10. And question 11, you're nearly there. And question 12. And question 13. And question 14. Oh, sorry. And final question before we go through. Okay, and that's time. Well done, everyone. I know it can be hard to sit through and do questions like that, but it's really good for your revision. If you get into a habit of practicing timed questions and particularly having a mix of topics, which will be representative of your exam. So we'll go through the answers now. I'm just going to load a poll, and if you guys can vote, we can see what everybody thinks. So we've got a 65-year-old woman presents to her GP complaining of a worsening erythematous rash around her right nipple. On examination, her GP notes the rash appears to be extending into the surrounding breast tissue. The GP suggests a punch biopsy might help in diagnosis. Given this woman's history, which of the following is best to describe her diagnosis? A, eczema of the nipple, B, Paget's disease of the nipple, C, inflammatory breast cancer, D, phyllodes breast cancer, or E, mucinous carcinoma. Sorry for that butchered pronunciation. So I'll just give you another moment for everyone to vote. If we get in the last votes, and then we'll go through the answer. Okay. So we've got a little bit of a mix there, but a lot of you were correct, and it is B, Paget's disease of the nipple, and I'll explain to you why. So Paget's disease of the nipple, as you can see on the picture, is when you have an eczematous change in the nipple, which is associated with underlying breast cancer. Actually, 90% of these patients, it's an invasive carcinoma. So it's one of the sort of more serious and further along staged breast cancers. Why is it not eczema of the nipple? They present very similarly, so I can see sort of where some people would get confused, but it's just important to remember that Paget's disease generally involves the nipple primarily and then spreads to the areola, but the opposite is an eczema. So where this had started in the nipple and then spread, you're thinking more of a Paget's disease picture than if it was sort of eczematous around the whole skin of the breast rather than focusing around the areola. It's diagnosed by a punch biopsy, so that was another clue for you. And we also use mammograms and breast ultrasounds to investigate. You know all about sort of the triple investigation, which we will go through a little bit later as well. Then treatment really depends on what's underlying. If it's invasive carcinoma, then you're assessing your treatment options for breast cancer, but we'll come to that on a later question. So question 2, I'll launch the poll again. Ooh. I need to stop sharing. Sorry, that was not very technological of me. So if everyone could vote again, we've got the NHS breast cancer screening programme is offered routinely to women aged 50 to 70. Which of the following patients would not be referred to breast clinic at a younger age? Got A, family history of breast cancer in 2 first-degree relatives at any age, family history of ovarian cancer, family history of breast cancer in a less than 40-year-old in a second-degree relative, family history of male breast cancer in a first-degree relative, or family history of bilateral breast cancer. Sorry, that one was a little bit wordier to read, but often MCQs will use terminology and you have to be really careful. I always liked, I know often the exams are online now, I quite liked highlighting it. I think you can do that on some online platforms to make sure that you've fully read the differences. So again, really good. A lot of you got that correct, and it's family history of female breast cancer in less than 40 years in a second-degree relative. There's a lot of criteria to remember. You possibly wouldn't be expected to remember all of them, but it is sort of quite an important part of the screening programme. So the screening programme is offered to women aged 50 to 70. it's every 3 years. In women over 70, they may still be referred for mammograms, but it's not part of routine screening. This is more if there's anything symptomatic, such as breast lumps, etc. But women at risk due to a family history are screened at a lower age. There's been a large push in terms of sort of awareness of breast cancer and BRCA genes and all that kind of thing in societal, but these are the sort of specific criteria where you would be offered younger screening. So first degree relative diagnosed at younger than 40 years. So that's why C was the correct answer for the last question. Under 40 years, you're wanting first degree relative rather than a second degree as the primary person that you're referring based on the family history. One first degree male relative at any age, one first degree relative with bilateral breast cancer, where the primary was under 50 years old, two first degree relatives, or one first degree and one second degree diagnosed at any age. Again, slight discrepancies in the wording of the question there. Your second degree relatives only coming alongside other relatives. And one first degree and one second degree relative diagnosed with breast cancer at any age, or ovarian cancer at any age. There's strong links between ovarian cancer and breast cancer. And then you've got, again, another wordy one, 3 first degree relatives or second degree relatives. So it's a little bit confusing to get your head around, but if you read through all of the options in those questions, hopefully you can kind of deduce, even if you haven't memorized the screening, that the closer the relative, the higher risk you are. And male breast cancer and bilateral breast cancer, because they're more rare, is why, again, you screen for them. Lovely. So question 3, I'll just launch the poll again. And if everyone can keep voting. A family history of breast cancer, including having the BRCA1 and BRCA2 genes, can increase your risk of getting breast cancer in a person's lifetime by over 40%. Which of the other risk factors can predispose to breast cancer? Progesterone-only hormonal contraception, late menarche and early menopause, breastfeeding, low BMI, or the TP53 gene mutation. I can see a couple of people still voting, so I'll give you a moment for everyone to get their votes in. I think I saw a question as well about what was the answer to question 1. I can go back to it, but also the session's recorded and we do send out the slides as well. So if there's anything you want to go through in your own time, you can get that by filling out the feedback link. And it looks like most people have voted there, so I'll share the poll with you. And this was a bit of a split bag, but again, most of you were right. It was the TP53 gene mutation. Again, another question where the wording, you have to be really careful to read for the differentiation in the risk factors. So some breast cancer risk factors, obviously we've already mentioned BRCA1 and BRCA2. They also link to ovarian cancer as well, so that's an important one to kind of remember. A first degree relative with breast cancer, such as your mother, again, that links back into the screening questions and why we screen these people at a younger age. The late menarche, early menopause, flipped around. So it's if you've had early menopause and late menarche, that's because you've had more years of sort of the hormones being more active and estrogen being produced centrally rather than peripherally, which happens when you're postmenopausal. Nulliparity or first pregnancy over 20 years, again, to do with hormones, increases your risk. And like I've just explained, it's early menarche, late menopause. It's the combined pill that raises the risk of breast cancer, and that's because of the estrogen component. So actually, it's sort of linking into your gynae and contraception modules there, but that's one of the contraindications to the contraceptive pill is a strong family history of breast cancer. Also hormone replacement therapy for the same reasons as the combined. Past breast cancer, you're not breastfeeding, ionizing radiation for sort of obvious reasons as would cause any cancer, and the TP53 gene mutation. Previous surgery can also cause an increased risk because firstly you're getting followed up a bit more, but the scars can hide the obviousness of a lump. So that's just something, again, to be aware of as some risk factors for breast cancer. It's quite a common cancer, one of the most common female cancers, and it's often quite treatable. So it's really important that we're being quite on it with the screening. And question 4, I'll launch that poll again. So a 54-year-old female has commenced on anastrozole for breast cancer treatment. Which of the following would be recommended to monitor or prevent an adverse effect of this medication? A, lifelong VTE, thromboprophylaxis with Plexane, which is also called enoxaparin, yearly ultrasound Doppler scans, HRT, a DEXA scan, or prophylactic bisphosphonate management. Just give you a moment because I can see people are still casting their votes. And again, we've got a bit of a split on this one, and everyone seemed to know that a common side effect of anastrozole is osteoporosis. So that's really good. Shows that you've got some good clinical knowledge there, but it's actually a DEXA scan rather than prophylactic bisphosphonates. I'm going to go through the hormonal therapies on the next slide. So we'll just go through question 5 as well, because they both link together, and then we'll go through why a DEXA scan was the right answer. So question 5, another one about neoadjuvant therapy. A 31-year-old female is referred under the 2-week wait after having presenting to her GP with a painless breast lump. She's found to have an ER-positive, estrogen receptor-positive invasive breast carcinoma. The cancer is operable, but neoadjuvant therapy is required to shrink the tumour prior to surgery. Given the history and diagnosis, which of the following therapies is most appropriate for this patient? Anastrozole, tamoxifen, Herceptin, radiotherapy, or chemotherapy? And we've had an overwhelmingly quick response on that one, so everyone seems quite confident with that one. So I'll share the results now. So the vast majority of you, well done, you are right, and it is B, tamoxifen. Big clue here was their estrogen receptor positive nature of the tumour, making this biological therapy the first line. So a bit more about anti-estrogen therapies. Personally, medication was always the bit I found the most confusing and like we had the least teaching on. So hopefully this is just a simplified way to think of it. So if you think about the mechanism of medications, it's often helpful to then help you understand what they do and why the treatment works. So tamoxifen is a selective estrogen receptor modulator. So it acts as an antagonist and partial antagonist of estrogen, which is why it's used to treat estrogen positive breast cancer, because it's specifically targeting that mechanism of estrogen. So if you think of the class when you're thinking of what it does, and then on that similar strand you can think of what the adverse effects would be for a medication targeting estrogen. So things like menstrual disturbance, you can get breakthrough bleeding, postcoital bleeding, intermenstrual bleeding, hot flushes. You're at higher risk of venous thromboembolisms, DVTs and PEs, and endometrial cancer. Despite this, despite being at a higher risk, we don't just put people on lifelong treatment Plexane. We only do that if they've had a VTE event, and it's generally 6 months if it's an unexplained, and 3 months if it's explained, but that's a slightly different topic to veer off onto. Again, hot flushes are a side effect of tamoxifen, so HRT may be used if a woman's struggling with that side effect of tamoxifen, but isn't necessarily routinely. And because the first question was focusing on anastrozole, that's why we were thinking about the osteoporosis. But that was the correct answer with the estrogen receptor positive. So then on to anastrozole, again, thinking about how it works. It's an aromatase inhibitor, so it stops the aromatization of it, so it blocks peripheral estrogen synthesis. I mentioned earlier that postmenopausal women, generally most of their estrogen production is peripheral, because essentially they've gone through menopause. The sort of like ovarian system isn't where the primary estrogen is produced. So while this is used for ER-positive breast cancer, it's used in postmenopausal women for this reason, and tamoxifen is the more appropriate choice for premenopausal women, which you're quite safe to assume in this 31-year-old, where it's not mentioned in the question that she's postmenopausal. That would be very, very early menopause, which is why that was the correct answer. As mentioned, again, because of this blocking of peripheral estrogen, it does put you at risk of, again, things like hot flushes, arthralgia, myalgia, all those kind of symptoms, but also osteoporosis. The NICE actually recommends a DEXA scan when starting patients on this. And if you have a look in the BNF at the osteoporosis treatment summary, it says you assess bone mineral density before starting treatment, and then you keep assessing it at regular intervals. So while prophylactic bisphosphonates might end up being used, they won't be used first line. You would do a DEXA first to see where you're at. Okay. So question 6, I'll just get the poll for you guys. So breast examination is often the first stage in identifying a breast lump. Which of the following changes on breast examination would be most indicative of specifically an inflammatory breast cancer as the main diagnosis? Scaling of the nipple, plus minus areola, purd or orange, however you want to say that, purulent yellow/green nipple discharge, galactorrhea, or nipple inversion. And again, looks like we've got a little split with this one. So I'll give you another moment for people to get the last votes in, and then we'll get to the answer. So it looks like the vote might have slowed down there. So I can share the results with you. And again, the majority of you have got that correct. This is a difficult one because a lot of the signs can blur into one, but we'll try and go through all of the different ones for each different thing. So it is purd or orange, which I'll describe to you shortly in changes, but just a note on breast examination, because it's a really common one. It's quite common that they can do an auscultation with it with a mannequin and give you a mannequin that has findings and has lumps to feel. And it's also really important because in a lot of specialties, including GP and ED, which are two of the major ones, you might end up doing this. So it's like any examination really, inspection and palpation, just missing the auscultation, percussion, etc. that you'd normally have. The things you're looking for, anything abnormal really, but some notable things: scars, asymmetry, masses, swellings, nipple abnormalities, and skin changes. You then ask a patient to put their hands on their hips and push upward, because this can move any visible masses. But if it's tethering and not moving, it's more likely to be a cancerous sign. Often benign breast lumps are quite mobile, and you get people to put their arms above their head. So if you think of the two poses, hands and hips and then arms above head, and again, that's to see the movement of the lump. Some breast changes can be, as with any body part, everybody is individual. So some breast changes, such as nipple inversion, can actually be a normal change. But any new changes or anything that you have any suspicion of as being slightly abnormal, it's best to investigate. So to palpate, you're using the flat of your hand and going around in a clockwise method, all 4 quadrants. And remember to palpate up the tail into the axilla. This is where you're going to be feeling for the breast lump. So you're wanting to think about how you're describing a breast lump. So where it is, use that as like a clock face on the breast is often a good way to describe location, size, shape, consistency, skin changes. Also palpate the nipples for any discharge, and you've already felt the axillary lymph nodes, but you also just want to do a lymphadenopathy check for any other lymph nodes. So some changes that were in the question. I think a few people had voted scaling of the nipple and the purulent discharge. So this is why it's the purd or orange. Its dimpling of the skin looks like an orange peel, hence the name in French. That's because of the lymphatic tissue causing edema, which is why it's typical of inflammatory breast cancer. So that's quite a characteristic sign of inflammatory breast cancer. Scaling is often more associated with Paget's, so like the question we had earlier on the erythematous changes around the nipple and then extending. That's why that's the incorrect answer for this question. The thick yellow, green, brown discharge, think of it kind of like your vaginal discharge. If you're getting abnormal discharge, it can often be caused by some kind of infection, and particularly green and yellow are always sort of the mucky colours of infection, even with sputum and things. So that's where you're thinking what breast infections might be causing this. You've got things like mastitis and breast abscesses as well. The milky discharge obviously is normal during pregnancy and when breastfeeding. But if it's come on when you're not breastfeeding, it is pathological. Generally represents a prolactinoma, which is a sort of benign milk producing tumor. So nipple inversion, like I said, can be a normal finding in some people, but if it develops without a cause, or if it's not something that's been there the whole time, or if a woman presents and it's not how her nipples have always been, investigated for pathology. Again, this can be caused by breast abscesses and mastitis, but also breast cancer. So again, it's an important one to rule out, and mammary duct ectasia. Watery or bloody discharge, there's a few causes, but really it's ductal carcinoma in situ that you're wanting to really rule out. We'll go through a bit more about discharge later, because there were some questions about that. And then erythema, like we've said, can be infection, trauma, such as fat necrosis, or underlying breast cancer, which would be your Paget's. Question 7, I'll just launch the poll, and we're about halfway. I'll try and keep it to as close as 8 o'clock as possible, because I know it's a long thing to do on your sunny Thursday evening. But a 36-year-old female presents to her GP 6 weeks postpartum with a painful, tender and hot left breast. She's currently exclusively breastfeeding. Other than the breast symptoms, she's otherwise fit and healthy, with a new score of 0. Given the likely diagnosis, what advice should the patient provide? The GP provide this patient? It's safe to continue breastfeeding. It's safe to continue breastfeeding, but this should be alternated with bottle feeding part of the time. It's not safe to continue breastfeeding. It should be ceased immediately. While on antibiotics, breastfeeding should be temporarily stopped, and urgent referral is required. I'll just give you a moment for that. And it looks like, again, people have voted quite confidently there. So you're absolutely right. It's safe to continue breastfeeding, because this is an example of mastitis, which is one of the causes of gunky discharge that we talked about earlier, and erythema. So this is inflammation of the tissue in the breast, which is often associated with breastfeeding. It can occur in a lot of women who are breastfeeding. In difference to breast abscess, you're generally systemically very well. It presents with a painful, tender, red, hot breast, but you can get fever and general malaise with it as well. But generally, with a mastitis, you're quite systemically well. Management is to continue breastfeeding. There's some sort of confusion there with whether it would be unsafe to continue, but because it's inflammation, not infection, it's actually beneficial to continue breastfeeding. You can just use a warm compress or analgesia, and if they're systemically unwell, or if cultures are positive for infection, if symptoms are persisting greater than sort of 24 to 48 hours, or if there's fissures present, then you're going to want to be treating against Staph aureus with oral Fluclox, which covers for that, because you don't want it to then develop into a breast abscess, which is what you want to avoid, because then you're looking at having to incise and drain it. But you can still continue breastfeeding on the antibiotics. So question 8, sorry, I'll just load that poll for you. A 20-year-old girl presents to her GP distraught as she's found a lump in her breast while showering. She's concerned that this could be cancerous, though she has no family history. She's diagnosed with a benign fibroadenoma. What information should the GP tell her about this diagnosis? The lump is likely to get larger over time. Fibroadenomas are benign but rare breast tumours. Surgical excision is always needed for a fibroadenoma. There's no increased risk of developing breast cancer. There's a significantly increased risk of developing breast cancer. Just give you another moment to vote. Any last votes? Lovely. Everyone's doing very well. With topics like this, with topics like kind of breast psychiatry, any topics that you might find easier, it's really good to have a really good grasp of, because it's quite easy marks in your exams, and also particularly sort of really important topics when you're sort of dealing with cancer. It's really important. So a lot of you were right there. There is no increased risk of developing breast cancer with fibroadenoma. Again, a really common misconception, and something that understandably young girls who sort of find a breast lump would be really worried about. So this is quite a sort of nice reassurance that the GP can offer in this case. So fibroadenomas are very common. They're not rare at all, really. They're very common in young women, particularly. They're hormonally driven, and sort of our whole lobule. The difference between clinically between a fibroadenoma versus a malignant lump is that it's very mobile rather than tethered. It's firm rather than craggy and irregular, and it's smooth. This isn't to say it shouldn't still be investigated in the same way, because we need to be sure, but clinically you can get an idea of whether it's presenting more as a benign or a malignant lump. Over about 2 years, 30% of them will get smaller, so they won't actually get bigger. There's no increased risk of malignancy. We're only really looking to surgically excise them if they're sort of large enough to be bothersome, uncomfortable. So if they're greater than 3 centimeters, that's generally when we excise them. You can do a mastectomy, but this is quite rare to have to do a mastectomy for fibroadenoma, because it is quite a sort of breast lump that can often be managed conservatively or just with a local incision. So question 9, I'll just launch, and you're well over halfway now, so you're all doing really well. You're a GP, you're an F2 in the GP. A 50-year-old woman presents with a breast lump that she noticed after a minor car accident where the airbed inflated into her chest. She has a past medical history of a BMI of 40, hypertension, type 2 diabetes, and hypercholesterolemia. You're concerned that the features of the lump may be malignant given the history. However, investigations are negative. Given the history, what is the most likely benign breast disorder responsible for this presentation? We've had a very confident vote there, so I'll end the poll there and share the results. And you're right, it is fat necrosis. I'm going to go through all of the benign breast disorders in one, because there's a couple of questions in a row. I grouped them together for the purposes of being able to explain. But when you're practicing, it's good to do a mix of doing topic focused revision after revising and doing sort of a mock exam, if you like, and doing a mix of questions. Both can be really useful for your revision. So question 10, we've got another breast lump question. Which of the following would be the most common cause for blood-stained discharge in a benign breast lump? A, breast abscess. B, ductal papilloma. C, mammary duct ectasia. D, fat necrosis. And E, fibrocystic disease of the breast. And I'll just give you a moment to vote there. We've got a bit of a split on this one. Last votes. Lovely. So the correct answer here was actually ductal papilloma. Again, I'll explain that why when we come to just after the next question, and explain what the difference between that and mammary duct ectasia is, because I can see there's maybe a little bit of misconception there. And question 11, final one on this little run. You are the F2 in an urgent care centre. A 54-year-old patient presents with a tender breast lump around the nipple alongside pure and clean discharge. She's recently commenced on HRT for symptoms of hot flushes and vaginal atrophy. Given the nature of the presentation is benign, which of the following is the most likely diagnosis? And this is probably giving you an idea of the huge range of benign breast disorders that there are. So often when there is a breast lump, it's important to investigate for cancer, but there's a lot of other causes and a lot of other things to consider in terms of management. So I'll just give you just another moment. And it looks like about everyone who's voting has voted. Final call. Lovely. It's also anonymous, the vote, guys. So if you're not sure, just punt it. In an exam, you'll always put an answer, so you might as well just punt it and say. So the correct answer for that was mammary duct ectasia. So there's your kind of difference. You've got the purulent green grotty discharge, and the HRT here was a hint, because it's often in postmenopausal women. So I've taken this very, very great table from the Past Medicine textbook, which is a good resource for sort of summarising information, as well as, of course, coming to our sessions. So you've got fibroadenoma on there, which we've already sort of discussed as being common in the younger population of women under 30. You've got fibrocystic disease, which is sort of similar to fibroadenoma, but it's not a solitary lump. It's generally sort of lumpy breasts, and it often worsens in menstruation. You've obviously got breast cancer, which is characteristically hard, irregular, can be tethered, associated nipple and skin changes. Got Paget's disease highlighted there as well, which we've also gone through. Represents eczematous changes. So think of it like that, but it starts in the nipple and then spreads slightly differently to eczematous. So mammary duct ectasia, which was the correct answer for the last question. This is where the breast ducts, dilate, which is common around the menopause because of the changes in hormones. So that's where the sort of HRT was a bit of a hint that it was this way inclined. It often presents with a tender lump, and then you've got that gunky green, yellowy discharge. It can cause local inflammation if it erupts. So then duct papilloma was the benign blood-stained discharge. So your main kind of differential there is it duct papilloma, or is it a type of invasive ductal carcinoma in situ breast cancer type of picture? This is where the mammary ducts, the cells have all proliferated, and that's what's caused the papilloma to form. It's hyperplastic lesions rather than malignant or pre-malignant, and this presents with that sort of blood-stained discharge that we've talked about. Fat necrosis was the answer to that first question. If you remember, again, you had some hints in the question. They'll generally give you quite barn door patients when it's something. So it's like the classic bladder cancer in a person who's worked with aromatic dyes, that kind of thing. They will often give you barn door hints in the question. They're barn door for a reason. They do happen in real life, but remember to sort of cast your net wider and consider the diagnosis in a lot of people. But it is often in obese women with large breasts, more fat tissue, and it can often follow trivial or unnoticed trauma. So your hints there were the airbags and the high BMI and history sort of relating to a lady being maybe a bit more overweight. This is an inflammatory response to that sort of trauma. It's probably a trauma that you wouldn't think of as an aggressive trauma, although airbags can be quite painful. And then it can develop into a hard, irregular breast lump. These are quite rare, and they do quite closely mimic what a malignant lump would look like. So this is one where you definitely want to get the further investigations, even in a patient with quite a barn door history like that. You wouldn't want to be missing a potential cancer. And we've talked a little bit about breast abscess with mastitis, but again, it's more common in lactating women. Red, hot, tender, and swollen. Okay. It's question 12, so you're all getting there, and you can go enjoy the last bit of the sun. A 39-year-old male patient is currently undergoing treatment planning for his recent diagnosis of breast cancer. His oncologist explains that he has palpable lymphadenopathy in his axilla and cervical lymph node, which has helped guide treatment. What addition to this patient's surgical treatment would be indicated given the lymphadenopathy? Neoadjuvant chemotherapy, whole breast radiotherapy, adjuvant hormonal therapy, sentinel node biopsy at primary surgery, which I think someone had asked in the chat earlier, that just means the first surgery, and axillary node clearance at primary surgery. So I'll just give you all another moment, and then I'll close that poll. Lovely. So another just little highlight in this question is not to discount male breast cancer as a presentation. it is a lot more rare than female breast cancer, but it is sort of a very important thing to sort of recognise and pick up and dispel stigma surrounding. So again, we had a bit of a split between the bottom two, which I'll explain the sort of similarities, but where they veer on the next slide. But the correct answer was axillary node clearance at the first surgery, which makes sense given that the lymph nodes have been sort of confirmed clinically. And we'll do question 13 now as well, because this is again a question relating to treatment of breast cancer. And then I'll go through both of the answers to those questions and just a bit generally about treatment of breast cancer. So which of the following would indicate a mastectomy being offered as first line for breast cancer as opposed to a wide local excision? Solitary lesion, small breast lesion, a ductal carcinoma that's less than 4 centimeters, a multifocal central breast tumor, or the desire to avoid cosmetic breast reconstruction surgery. And I'll just give a moment for that. And it looks like a lot of you have voted. Lovely. Hopefully you guys are finding the poll function quite helpful to sort of keep you engaged. So the correct answer, again, the vast majority of you, very well done, is if it's a multifocal central breast tumor. So a bit on treatments, and surgical treatment of breast cancer is the sort of most common and generally the first line. Nearly all patients are offered surgery. It's quite treatable, generally, cancer surgically, and even the more advanced stages of breast cancer can often have benefit from surgical management, where you can do a whole mastectomy to remove the whole breast. Very rare sort of cases where it's a very elderly, frail patient with multiple comorbidities who either doesn't want the operation or it would be dangerous to anaesthetize and put on the table. It's kind of the only real exception to patients being offered surgery. This just shows you the difference between the wide local excision and the total mastectomy, which I don't want to patronize anyone with, because I know everybody is probably very aware of mastectomy, but just involves you're conserving the breast tissue and just removing the tumor and any associated lymph nodes, whereas a mastectomy is obviously removal of the whole breast. And women have the option to get surgical reconstruction or to just keep the scar. So the presence of the axillary lymphadenopathy means that firstly the cancer is probably more progressed because you've got lymph nodes present, but it also helps guide the management a little bit, because if there was no palpable lymphadenopathy, you would still want to check if there is any, because sometimes it can be really difficult to feel, especially in the early stages. And you can probably all appreciate from doing lymphadenopathy examinations, if it's a tiny lump in the axilla, it's really difficult. But then you want to do an ultrasound just to make sure there's definitely no lymphadenopathy, and then if you've got the positive ultrasound, you're doing the sentinel node biopsy to determine what the lymphadenopathy is, what you're working with, and then guide treatment from there. Whereas if it's palpable, you're just clearing the axillary nodes at the first surgery. Don't need any messing about with an ultrasound, we're just removing them straight away. It's quite a sort of cut it out kind of approach. This is another great table taken from the PassMed textbook, which just shows the difference in indications for mastectomy versus wide local excision. It kind of makes sense if you think about it. Mastectomy is a lot more invasive and a lot more, gets rid of a lot more. So that's why a multifocal central tumour, you'd be looking at, obviously patient choice as well, but you'd be suggesting mastectomy as first line. Whereas if it's just a solitary lesion, if it's on the periphery of the breast, you can probably do a more breast conserving surgery. If it's a large lesion in the breast, again, just sort of makes sense as to how invasive and how much breast tissue you're removing versus small lesion. And if it's a ductal carcinoma in situ over 4 centimeters, that's why that is. You're on your last 2 questions and you're all doing very well. If you're getting any questions wrong, don't be disheartened. Often you learn a lot from getting questions wrong. It often helps you remember things. So actually it's still a really positive learning experience. And just go through a bit about the other kind of treatments that were options there, and a bit about just generally breast cancer treatment. So whole breast radiotherapy is often recommended after a wide local excision to reduce the risk of recurrence. This is because you haven't obviously removed as much / all of the breast tissue like you have in a mastectomy. So by doing the radiotherapy, it's just an extra layer of trying to reduce risk of recurrence. But in a mastectomy, it is still sometimes offered for those more advanced T3, T4 tumours, or if there's positive axillary lymph nodes, because that is a more advanced tumour. Despite removing the whole breast, it's a higher risk of recurrence. So you'd offer it there to again reduce the risk. Biological therapy, linking back to our earlier questions about anastrozole and tamoxifen. Trastuzumab or Herceptin, you might know it as sort of its brand name, rather than the estrogen receptor positive tumours that we were talking about earlier. This is the HER2 positive tumours. It's not as effective, and HER2 positive tumours don't have as good a prognosis as estrogen receptor, but trastuzumab is a good addition for targeting the HER2 receptors. Chemotherapy can be used prior to surgery, neoadjuvantly, or adjuvantly with and after surgery. The aim, as with any chemotherapy, is to try and shrink the tumour. So it might be done prior to surgery to try and shrink the tumour, particularly before wide local excision, where you're trying to conserve as much breast tissue as possible. Sometimes it's done after, but that kind of depends on the stage of the tumour, and that's very high clinical, medical, oncological. That's probably a bit above finals level, but it's just important to know that you can use it adjuvantly or neoadjuvantly. Question 14, you've just got 2 to go. So the 2-week wait for breast cancer screening has specific eligibility criteria. Which of the following would warrant a non-urgent referral to breast clinic rather than a 2-week urgent cancer referral? Just a disclaimer, just for sort of your own clinical practice. If you're ever uncertain about something, obviously always ask a senior, but you're better referring a breast lump under the 2-week wait as opposed to non-urgent if you're really worried about someone. It's just as a general clinical note. And that's the same with anything. Okay, so we've got A, under 30 with an unexplained breast lump, plus minus pain, 30 with this, 30 with an unexplained lump in the axilla, over 50 with either unilateral nipple discharge or unilateral nipple contraction. And again, a large majority of you are very correct there. It is the under 30-year-olds with unexplained breast lump and pain. An exception to this, coming back to one of our earlier questions, would be if they had a really strong positive family history. You'd be looking at the 2-week wait. But generally for those patients younger than the screening age, if it's not got a positive family history, it would be a non-urgent referral because it's more likely to be a fibroadenoma. But again, if you're not sure, just do check. So I've taken this from the NICE guidelines about the 2-week wait, and the NICE guidelines, as with everything, are really useful, but they're really good for sort of all cancer referrals and 2-week waits. But you refer people who are 30 or over with the unexplained breast lump, 50 or over with changes in one nipple. Changes in one nipple are more likely to be cancerous because it's showing that it's more likely to be caused by some kind of underlying tumour that's not in both breasts, whereas bilateral changes are more likely to be benign lesions. And then you want to refer people with skin changes suggestive, so that purred orange perhaps, or any eczematous that you're thinking about, Paget's, 30 or over with a lump in the axilla as well. And then you're considering non-urgent referral in the under 30s. Again, the family history can be the exception to that. Again, not guidelines that you need to remember like word for word, but you can work that out based on your clinical knowledge of breast cancer and what's more likely to be cancerous, or you can learn them off by heart. Question 15, so we're on the final question. Well done everyone for sticking it out, and if you do have to leave, I know it is 8 o'clock, so if you could just fill in the feedback form, I'd be very grateful. An 18-year-old female presents with fluctuating breast pain relating to her menstrual cycle and is diagnosed with benign cyclical mastalgia. Which of the following management options is first line? Hormonal therapies, wearing a supportive bra, avoiding analgesics because it's hormone related, non-urgent referral to breast clinic or urgent referral to breast clinic. So I'll just give you a moment for the people who are sticking with us until the end. And is that most people have voted? Lovely. Just a more simple one to end on. But the correct answer was B, wearing a supportive bra. So I can completely understand why people have put hormonal therapy. However, cyclical mastalgia, it's really important not to discount, but it can often be managed by quite conservative measures. They can make a big difference. So you're always trying to do conservative measures first line and then work up to more complex measures. And obviously giving hormones has its own set of risks and side effects. So if you can manage it with more conservative measures, you're not then putting people on hormonal therapies and increasing the risk of those kind of side effects. It's a very common cause of breast pain in young women. It presents cyclically and is associated by hormones. It's difficult to say an underlying cause. It's a little bit like endometriosis in that it's a little bit less understood, but it's very, very valid and can be quite painful. And it can be caused by things like breast cysts, they think, but again, the pathophysiology is still sort of up for some debate. But it presents around your hormonal cycles. So things like a supportive bra and analgesia sound really simple, but can make quite a big difference for this. However, if it's not responding to conservative measures after 3 months, or if it's affecting women's quality of life, which is huge, then definitely consider a referral. And hormonal agents can be used, but again, there's a lot of side effects associated. So that's why we want to try those conservative measures for 3 months and then move on to more complex things. So thank you very much, everyone, for coming. Hopefully that was useful. Again, like I said, for a lot of you did quite well on those questions, but it's really important to remember to use your this to your advantage and make sure you're still revising topics that you feel more comfortable with, because it's kind of guaranteed marks. We have these sessions every Thursday until June at 7 p.m. by the same Zoom link that you've joined today. You can see on our Facebook page what each session is going to be each week. We've got a really great variety and we're covering basically everything. It's a really great way to revise in the run up to your finals. It's a nice, concise, it's an hour session covering, I've not covered all of breast today, but we've covered a really good chunk in a concise way. So hopefully you guys found it useful, and have a lovely rest of your evening. Thank you for joining, and if you can please fill out the feedback
Sophie,
form, it's really useful for
just one thing. There was
so we know how to help you guys improve.
Just one thing. There was
I'll end it there if everyone's. Oh, Brad, I can't hear you. Were you talking?
Yeah, I was. Sorry.
Cool.
There was
okay, I'll end this here. Thank you, everyone. Have a nice rest of your evening.